Okay, dear friends, we'll do the rapid revision of upper limb trauma. Okay, so I'll do it fastly, quickly. For detailed explanation, just go through our main recording. Okay, this is rapid revision. So the very first topic is fracture clavicle. Very, very important topic. The first point, we should concentrate on anatomical peculiarities of clavicle. Clavis means key. Key means immediately we will think only of lock and key. That's not the answer. Key here refers to a musical symbol, musical key. Okay, it is musical key. Okay, we all know that music directors used to write notations like this. Yes or no? Is this not looking like a S-shaped bone? That's why it's called clavis. Okay, first bone to ossify in the body. When it first ossifies, okay, when it ossifies, it starts ossifying by 5th week of intrauterine life. First bone to ossify in the body, very peculiar, and it's the last bone to complete ossification. Okay, what is the answer? 25th year of life. Okay, 25th year of life. Okay, 25th year of life. And you see, always one bone will have one primary center. This is the only bone which has two primary centers, right? And we all know that long bones ossify enchondrally, flat bones ossify membranously. This is the only long bone in the body to ossify membranously. Very peculiar. Two types of ossification: membranous ossification and enchondral ossification. As a rule, all long bones ossify enchondrally, all flat bones ossify membranously. This is the only long bone to ossify membranously. Very important. Only long bone that doesn't have any medullary canal. That's very important. Long bone means we'll have a cortex and a medulla. This doesn't have a medullary canal. And clavicle, most common bone to be fractured in newborn. Okay, very peculiar. Newborn, it won't walk or fall down. What's the cause? Birth trauma. Okay, right. Now, what are the deforming forces? When you see, we all know the most common site of fracture clavicle is medial 2/3, lateral 1/3 junction. Okay, so what are the deforming forces? The lateral third is pulled down by weight of upper limb. Weight of the upper limb. Okay, medial 2/3 is pulled up by sternocleidomastoid. Sternocleidomastoid. Okay, so medial 2/3 is pulled by sternocleidomastoid. Lateral 1/3 is pulled down by weight of the upper limb. So always when fracture clavicle happens, definitely there will be a deformity. There will be a displacement. Okay, so always fracture clavicle will unite. It will unite with malunion, minimal malunion, however much you correct. Okay, that is why when you are doing treatment, conservative is the best management for fracture clavicle. We are doing that management by correcting these deforming forces. Okay, that I will come at the end in the treatment. You see, what mechanism? Most common, see why I am stressing this point, dear friends, you should be very careful in answering our MCQs, because upper limb trauma means most common mechanism is always fall on outstretched hand. That's the general teaching. Colles fracture, scaphoid fracture, both bone forearm fracture, supracondylar fracture. Whatever it is, no, the most common mechanism is fall on outstretched hand. But clavicle fracture, that's the least common mechanism. Fall on outstretched hand is the least common. Book says it's only 2%. Then what is the most common mechanism of fracture clavicle? Fall onto the same side shoulder, fall onto the affected side shoulder. This is what it happens. Patient will be walking, some stone, something is tumbling over the stone, fall onto the same side, direct hit over the lateralmost end of the clavicle, clavicle is gone. So the book says this is 87%. Second thing is fall like this, direct hit over the clavicle. That's the second common mechanism that we are not bothered. Most common mechanism is fall onto the same side shoulder. Least common mechanism is fall on outstretched hand. This is the point I want to stress, dear friends. Now, most common site of fracture, I told you, this has been asked 1 lakh times. Medial 2/3, lateral 1/3 junction. Okay, lateral 1/3 junction. So this is the most common site. 1 lakh time repeated MCQ. Most common site of fracture clavicle is medial 2/3, lateral 1/3 junction. X-ray view of choice. Obviously, the deformity, everything will be there. Confirmation is by X-ray. X-ray, normally in our OP, we will take AP view, anteroposterior view, fracture clavicle with the shoulder, shoulder AP. This is normal. But MCQ, the specific view or view of choice X-ray view of choice to visualize clavicle. Already I had stressed this point when we were discussing in rapid revision and in main recording. Special X-ray views in ortho. There's a separate topic. You go through that once again. Again now I'll tell. The best view is called 45-degree lordotic view. 45-degree lordotic view. Okay. That's the best view or view of choice. CT scan, is it indicated? Yes, CT scan is indicated. When it is indicated? When the fracture is at the lateralmost end of clavicle, CT scan is a must, because I want to rule out that is there any intra-articular extension. So this, when you suspect intra-articular extension, okay, articular extension, right, CT scan is a must. So it is indicated in lateralmost clavicle fracture. Okay, lateralmost end of clavicle fracture. Okay, and this is otherwise called acromial end. Whenever there is an fracture near the acromial end, CT scan is a better investigation than X-ray, because near the acromium, sometimes the clavicle fracture may go inside the acromioclavicular joint. So intra-articular joint extension can be assessed only with CT scan, not with X-ray. Right? Okay. Now, is there any classification system? Yes. In all fractures, one classification system will be there. The only classification system which is accepted throughout the world is called Allman and Craig's classification. Group 1, Group 2, Group 3. Very simple. Group 1, middle third. This is the most common type. Group 1. Group 2 is the lateral end of clavicle. It's 15%, second common type. Okay. Group 3, this is group 3. Okay. This is not group 1. Group 3. Okay. Group 3, medial most end of the clavicle. This is the least common. Okay. This is the incidence. Clavicle fracture happens 80% middle third, 15% lateral third, only 5% medial third. This is called Allman and Craig's classification, because only when you classify the fracture we can plan for management. The best management is conservative. Okay. For this, the best management is surgical. We should know. Okay, they may ask a clinically based question or image based question. They may ask you what's the best management, which confidently we should answer yes. Now coming to treatment options. Conservative treatment is 90% of fracture clavicle is treated conservatively. Only 10% needs surgery. All cases of fracture clavicle we will not do surgery. Only 10% needs surgery. 90% needs conservative management. What are the conservative managements that are possible? This cuff and collar sling and figure of 8 are the gold standard. Okay, these are the gold standard. Right? Very simple. We all seen cuff and collar sling is like this. You are flexing the elbow to 90. You are adducting the arm to the chest and you are tying with a cuff and collar sling. This is one. With this, you should mix figure of 8 bandage. You see in the diagram, we're able to see, this figure of 8 bandage, all of us would have seen figure of 8. What is the purpose of these two? When I give a cuff and collar sling, the lateral 1/3, the deforming forces, you remember, was pulling down, that is neutralized. I said, you just see this diagram, dear friends. You see these deforming forces? Lateral 1/3 is pulled down. Yes or no? This is pulled down by weight of the upper limb. This is neutralized by your cuff and collar sling. Medial 2/3 is pulled up by sternocleidomastoid. That is compressed, that is neutralized by your figure of 8. So when you give figure of 8 with cuff and collar sling, both these deforming forces are neutralized. Since it's a membranous bone, it will heal quickly. Okay, it will heal quickly within 6 weeks. Fracture clavicle automatically will heal. That is why the management of choice for fracture clavicle, mostly it is 90%. If it is middle third, Allman and Craig's. Type 1, it is conservative. And what is the conservative management we do? Cuff and collar sling with figure of 8 bandage. Okay. Now, strapping. You just do a strapping over the fractured site. Sabry's and Billington Yoke's method are outdated, but for MCQ, you should know this name. Sabry's method is nothing but putting a rigid dressing over the strapping, over the fracture site, then you are applying strapping. A rigid dressing, a thick dressing with your Gamgee pad over the fracture clavicle, then you are putting a tight strapping. That's called Sabry. Billington's Yoke's method, again, it's outdated. You are putting figure of 8 bandage. You are reinforcing that figure of 8 with plaster of Paris. That's called Billington Yokes. When you apply over the figure of 8, when you apply plaster of Paris, it will be very tight. It's very effective but very tight, and it causes breathing difficulty to the patient. So these methods are outdated. Just for MCQ, you should know. Now, age-wise treatment plan is very simple. 0 to 2 years, over 2 years. Okay, more than 2 years. Right? 0 means from birth to 2 years. Then more than 2 years. Okay, more than 2 years. 0 to 2 years, only strapping is enough. This is the only special point. 0 to 2 years, from birth to 2 years, no figure of 8 is allowed for that baby. Just a strapping cuff and collar sling is enough. More than 2 years, advisable best thing is to put a cuff and collar sling and your figure of 8, right? Okay, this is just very simple. Indications for surgery. When will you, that I said that 10% needs surgery. When will you do surgery? When will you do surgery? Okay. Number 1, if it's a compound fracture or open fracture, you have to do surgery. Number 2, injury to the neurovascular bundle. Fracture clavicle is presenting with subclavian artery injury or brachial plexus injury. You have to open and fix it with a plate. It decompress the nerve and vessel, then you should fix it with a plate. So definitely its surgery is indicated. Number 3, associated rib and scapula fracture. Clavicle fracture, whenever the most common fractures that are associated, when you fall down like this, clavicle is gone, rib is gone, scapula is gone. So associated scapula and rib fracture, you can't put figure of 8 because rib fracture is there. How will you tight the figure of 8? It will hurt the patient. So you have to go for surgery. That's a must. Non-union. You tried your conservative method even after 3 months. There is no radiological sign of union. You have to go for open reduction internal fixation with bone grafting. Now, any non-union anywhere in the body, treatment of choice is only surgery. Then fracture near acromioclavicular, lateralmost end of clavicle, lateralmost end of clavicle, you have to do surgery, no other go. And bilateral fracture clavicle, you have to do surgery. Only 6 indications are mentioned in Campbell for surgical indication for fracture clavicle. Okay, open fracture or compound fracture, associated neurovascular subclavian artery injury or brachial plexus injury, associated rib and scapula fracture, non-union fracture near acromioclavicular joint, bilateral fracture, bilateral clavicle fracture. This is a very important area, especially in INI-CET, dear friends, because repeatedly several times in AIIMS they had asked this question. For INI-CET type of exam, all are indications for surgery except. It's a sure question. Yes. Coming to complications of fracture clavicle, most common complication of fracture clavicle is malunion. However much you reduce, minimal malunion, but that's not going to affect movement of the shoulder joint. No way fracture clavicle is going to affect the movement of the shoulder joint. So it's, except for minimal cosmetic reason, it is acceptable malunion. So don't do surgery for good anatomical reduction. That's not an indication in clavicle. In all other bones, why are you doing surgery? Early mobilization and perfect anatomical reduction. That is not an indication for surgery in fracture clavicle. That's exception. Most common vessel that is injured in fracture clavicle is subclavian artery and subclavian vein. Most common nerve that is injured in fracture clavicle is medial cord of brachial plexus. Medial cord of brachial plexus has many nerves, Medial cord of brachial plexus has your medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, ulnar nerve, medial pectoral nerve. 5 nerves are there. So you may be doubt. I repeat once again. Medial cord of brachial plexus has median root of median nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, ulnar nerve, medial pectoral nerve. 5 nerves are there. Among that, you may be doubting which nerve will go for common injury. I will give the answer straight away. Ulnar nerve. That's what is given in higher books. Very commonly affected nerve, ulnar nerve. So medial cord of brachial plexus is a broad answer. It's a wide answer. You want to narrow down into MCQ, ulnar nerve is the answer. And most common associated fracture is rib fracture and scapula fracture. And Fracture clavicle is an important cause, whether it's malunited, is an important cause for thoracic outlet syndrome. You all know thoracic outlet syndrome. Cervical rib, we had studied thoracic outlet syndrome, is an important cause. With your cervical rib, you should add fracture clavicle, which is malunited. Okay, to some extent, we have completed the topic fracture clavicle. Okay, dear friends, we'll see the next topic, shoulder dislocations. See, there are 65 joints in human body. The most common joint to undergo dislocation is shoulder. Okay, commonest dislocation of human body is shoulder. Okay, right? Types of shoulder dislocation, it is divided into 3 types. Okay, number 1, it is anterior shoulder dislocation. Anterior shoulder dislocation. Number 2, posterior shoulder dislocation. Number 3, inferior shoulder dislocation. Inferior shoulder dislocation. Okay, 3 types are there. Okay, anterior, posterior, inferior. Right, this is the most common. This is the second common. This is the least common shoulder dislocations. Okay, this is the least common shoulder dislocation. Right, so anterior, posterior, inferior. Okay, the most common is anterior shoulder dislocation, the least common is inferior shoulder dislocation. Yes. Now, all the classical clinical, the commonest, whenever somebody is getting shoulder dislocation, 99% it should be anterior shoulder dislocation. And there are few important clinical signs very clearly explained in our main recording. Just we'll rush through once. When the patient arrives at your outpatient department, just by looking at the emergency, you can say what type of shoulder dislocation it is. If it is anterior shoulder dislocation, number 1, the deltoid contour is lost, roundness of shoulder, because it's a ball and socket type of joint. The socket is your glenoid cavity and ball is head of the humerus. It will slip out of the glenoid cavity. So, the roundness of the deltoid, the contour of the deltoid is lost. Deltoid appears flat. Number 1. Number 2, shoulder is extended. Attitude, no? Shoulder is extended, slightly abducted, externally rotated. Patient will come to the OP like this. The upper limb is extended, abducted, externally rotated. When you ask the patient to touch the opposite shoulder, patient can't touch the opposite shoulder. That is called Dugas test. That's called Dugas test. When you keep a ruler, normally when you keep the ruler, because of the deltoid contour, okay, like this, the upper end and the middle, when it touches the lateral epicondyle, there will be a gap here and the gap there. That is normal. Since ball is out of the socket, the deltoid contour is lost. In affected side, when you keep a ruler, from top to bottom, it will totally flushes with the upper limb. So arm. That is called Hamilton ruler, one of the very old clinical signs in orthopedic. Then comes Calave's test. Take an inch tape, measure the girth of the axilla, width of the axilla. On affected side, width is more. That is called Calave's test. Then comes Bryan's test. Normally, all of us has an anterior axillary fold. If it is shoulder dislocation on the affected side, the anterior axillary fold is pushed down. That's called Bryan's test. Right? And the commonest nerve that is compressed in shoulder dislocation is axillary nerve. So, patient will have loss of sensation over the deltoid. And that's called regiment badge. This is a spelling mistake. B-A-D-G-E. Regiment badge test. Okay. So, what are the clinical signs? Loss of roundness of shoulder. Attitude of the upper limb extended or abducted, externally rotated. Positive, patient not able to touch the opposite shoulder. Dugas test, Hamilton ruler's test, Calave's test, width of the axilla on affected side is increased. Bryan's test, the anterior axillary fold is pushed down. Regiment badge test, loss of sensation over the deltoid. Regiment, army officers, regiments. Okay, usually they will have the regiment badge over the deltoid. And those area, since the axillary nerve is compressed, there is loss of sensation, hyposthesia or anesthesia. That's called regiment badge test. Okay. Now, coming to radiological finding, when you take an X-ray AP view of the shoulder, there is no named clinical signs for anterior shoulder dislocation. That's the commonest dislocation. There is no named sign in any textbook. When you take an X-ray, AP view, you see I am able to see the glenoid but not clearly because head of humerus is overlapping the glenoid. This is how an anterior shoulder dislocation looks. If it is posterior shoulder dislocation, when you see, I can see the glenoid cavity totally empty here. Total glenoid I am able to visualize. Here the full glenoid I am not able to visualize because head of the humerus is lying in front of the glenoid. In anterior shoulder dislocation, and the head of humerus is lying in front of the glenoid. That's why it's called pre-glenoid. That's the most common type of shoulder dislocation. Head of humerus is lying in front of the glenoid. So it's called pre-glenoid, most common type. Okay, posterior, head of humerus is lying behind the glenoid. So I am able to see a very, very clear vacant glenoid. This is called vacant glenoid sign. Posterior shoulder dislocation. Posterior shoulder dislocation. Vacant glenoid sign. When you see this, the head of the humerus stands separate and looks like a 40 watts Phillips bulb. So this is called light bulb sign. Okay, this is called light bulb sign. Very old books uses the word daylight sign. The books now, new books now, it's called light bulb sign. Light bulb sign. Okay, so like a light bulb, right? You see here, right? So a vacant glenoid sign and a light bulb sign. Two named signs are only for posterior shoulder dislocation. That's the point I want to. If it is inferior shoulder dislocation, it's the least common type. What happened? Head of humerus is inferior to the glenoid cavity. So your arm, patient's arm will be like this. Patient's arm will be like this. Shaft of the humerus is erected. So inferior shoulder dislocation is otherwise called luxatio erecta. Inferior shoulder dislocation is otherwise called luxatio erecta. Luxatio erecta. Okay? Yes. Now, coming to two important lesions in shoulder dislocation. Shoulder dislocation is happening. It's not happening directly. It is causing some damage to the soft tissues. It's causing damage to head of the humerus. Damage to the soft tissue is called Bankhart's lesion. Damage to the bony portion of the head of the humerus is called Hill-Sachs lesion. So what is Bankhart's lesion? Bankhart's lesion is damage to the anterior structures. That is your capsule and the labrum. Where it happens anteriorly, anterior alone is not enough for our entrance. It is antero-inferiorly. Bankhart's lesion happens antero-inferiorly in the capsule and the labrum. Bankhart's lesion is a pure soft tissue disruption which is happening antero-inferiorly. So I used to give the mnemonic for our guys. Bankhart's starts with the letter B. So the mnemonic is BY. The mnemonic is BY. Bankhart's antero-inferior. You won't forget in the exam. So since it's a soft tissue lesion, how you can detect this? MRI. How to detect this? MRI. Yes, Hill-Sachs lesion is a bony lesion. Where this is happening in head of the humerus? Posterolaterally. Okay, posterolaterally. There is a defect. You see a depressed fracture-like thing, a dimple-like thing. You are able to see here a real autopsy humerus of Hill-Sachs lesion. I am able to see a depressed fracture-like thing, a depression in posterolateral aspect of head of the humerus. See, this is an X-ray. I am able to see a defect in the posterolateral aspect of the head of the humerus. This is called Hill-Sachs lesion. So, you see posterolateral, Hill-Sachs, HPL is my mnemonic. HPL is my mnemonic. Hill-Sachs posterolaterally, HPL, famous computer company, Hewlett-Packard Limited. You won't forget, no, HPL. So, by, it is Bankhart's lesion, by Bankhart's antero-inferior, Hill-Sachs, HPL, posterolateral, head of the humerus. Since it's a bony lesion, you can see sometimes in X-ray, but definitely in CT scan. So this is a bony lesion. This is a soft tissue lesion. That's the difference. These two are very important, repeatedly asked MCQs, dear friends. Now, you should know what is terrible trade of shoulder. Shoulder dislocation has happened. Always we will do MRI to rule out Bankhart's lesion. So what is terrible trade of shoulder? Number one, the same shoulder, patient is having a Bankhart's lesion plus Hill-Sachs lesion plus erosion of the anterior glenoid rim. So, when the patient has Bankhart's lesion plus Hill-Sachs lesion plus erosion of the anterior glenoid rim, this combination is called terrible triad, otherwise called unhappy triad of shoulder. Unhappy triad of shoulder, because whenever you get this combination, guaranteed that the patient will go for recurrent shoulder dislocation, the very big complication of shoulder dislocation. Recurrent shoulder dislocation, that is the significance of terrible triad of shoulder. Coming to treatment, the first tried technique was Hippocrates method. Or the patient to lie down, just you catch hold with your upper limb, the affected limb, you take your foot, put it in the axilla, you push it, that's you are giving counter traction, you are pulling the upper limb, pushing the axilla, shoulder dislocation will get reduced. It's a very effective method, but nowadays, Hippocrates era, it's before Christ, that's okay. Now when you do this, that's playing with morality of an individual, so nobody will accept, so it is outdated. Outdated means not effective. This doesn't mean it's not effective. It's very effective, but it's playing with dignity of an individual, so it is not. Next is called Stimson's gravity method. Not very much useful, practically it's not a good method. Put the patient in prone position, ask the patient to hang, put a weight over the wrist. Because of gravity and the weight, shoulder dislocation may get reduced. This is, practically speaking, the best method or technique of choice. Most commonly followed or technique of choice, treatment of choice or technique of choice is Koch's method. Koch's method. The patient is lying down, you are giving traction, external rotation, you are giving traction, external rotation, adduction, medial rotation. So, you see the first letters, traction, external rotation, adduction, medial rotation. Is this not for framing a mnemonic team? So this is called team technique. This is the treatment of choice or technique of choice. 1 lakh time repeated MCQ. Now, coming to surgeries, if the patient had gone for recurrent shoulder dislocation, it cannot be treated conservative like your Koch's method or something. It needs some surgery. Many surgeries are available. These 6 names commonly asked in our Indian entrance. Most acceptable surgery, Bankhart's operation. Second accepted Putty plots, then Bristow's, McLaughlin, Weber's. This is not Nicola, this is Nicolandi. Nicolandi, this is the correct spelling. Nicolandi method, okay, Nicolandi. So these are the surgeries. In this Putty plots is double breasting the subscapularis muscle. Okay, it's called Putty plot, double breasting the subscapularis muscle. Just remember the names. Among the best widely followed technique for recurrent shoulder dislocation throughout the world is Bankhart's procedure, Bankhart's operation. Technique is not needed for us, for our NEET PG. That's okay. Now coming to complications of shoulder dislocation. Most common nerve that is injured in shoulder dislocation is axillary nerve. Posterior brachial plexus is not needed. Okay, it's axillary nerve. Axillary nerve is a part of posterior brachial plexus. Most common artery that is damaged is axillary artery, and this is the most common joint to undergo recurrent shoulder dislocation also. So, 2 MCQs, dear friends. Most common joint to undergo dislocation is shoulder. Most common joint to undergo recurrent dislocation is also shoulder. When it has gone for recurrent shoulder dislocation, for our INICT, you should know there are 2 types of recurrent shoulder dislocation. One is called Tubbs type. This is a mnemonic. Another is called Ambry type. A-M-B-R-I, Ambry type. Okay, this is very important. What do you mean by Tubbs type? The cause is traumatic. The cause is traumatic. U stands for unilateral, unidirectional. I will explain. Unidirectional. B stands for Bankhart's lesion. Bankhart's lesion. S stands for surgery. What does it mean? If a patient, when it is called recurrent shoulder dislocation, one time a dislocation happens, that's not called recurrent shoulder dislocation. More than 3 dislocations in a speculated time of 12 months. Strictly speaking, theoretically speaking, MCQ wise speaking, who is having recurrent shoulder dislocation? What is the definition of recurrent shoulder dislocation? 3 or more dislocation within a speculated time of 12 months is called recurrent shoulder dislocation. Practically speaking, when second time shoulder gets dislocated, that's called recurrent dislocation. But we are not bothered about practical things now. We want to get a seat. It's NEET PG exam. So PG exam, what is called recurrent shoulder dislocation? 3 or more dislocation happening within a period of 12 months. Then it is called recurrent shoulder dislocation. When somebody is having recurrent shoulder dislocation, you should evaluate what type of recurrent shoulder dislocation is that. That's the 2 types, Tubbs types, Ambry type. Tubbs types, Ambry type. This is the classification. Okay. So, what is Tubbs type? The cause is traumatic. The patient says that I had undergone trauma. The etiology is trauma. T. And unidirectional. What do you mean by unidirectional? First time dislocation happened, it is anterior shoulder dislocation. Second time dislocation has happened, it is anterior shoulder dislocation. Third time the dislocation has happened, it's also an anterior shoulder dislocation. That's called unidirectional. Okay. Then you are doing an MRI showing you Bankart's lesion. Definitely Bankart's is there. The treatment of choice is surgery. For this only you are doing these surgeries. Bankart's procedure, Putty-Platt's procedure, McLaughlin procedure, all these surgeries you are doing for Tubbs type. Okay. If the cause is atraumatic, Ambry type, atraumatic, multidirectional, bilateral, here this doesn't stand for Bankart's, bilateral, rehabilitation, inferior capsular shift. I explained this. If otherwise the patient is having a recurrent shoulder dislocation, the patient is telling the cause is not trauma, atraumatic. It happens spontaneously, atraumatic. And multidirectional. First time, sir, it was anterior shoulder dislocation. Second time, it was posterior or inferior. Third time, again inferior or posterior or anterior. So, it's going multidirectional. Second point. And both the shoulders are getting dislocated, bilateral. Then the treatment is not surgery. If it is atraumatic, multidirectional, no use of doing surgery. Only for unidirectional traumatic case associated with Bankart's, you can repair that Bankart's lesion, you can do surgery. If it is happening multidirectional, that means whatever surgery you do, it is not going to work. So, no surgery. Then what's the treatment for this Ambry? Rehabilitation. Physiotherapy. Rehabilitation. If at all in olden days a surgery was done, the surgery was called inferior capsular shift. You are shifting the capsule inferiorly, you are creating an artificial shoulder joint, artificial glenoid cavity. That's called inferior. These are historical interest. Okay. So, in our exam, traumatic shoulder dislocation, recurrent shoulder dislocation, surgery is the treatment of choice. Atraumatic recurrent shoulder dislocation, treatment of choice is rehabilitation. Okay. So, with this, to some extent, we have completed the topic shoulder dislocation. Okay, dear friends, we'll move on to another important topic, humerus fractures. See, humerus fractures are divided into proximal humerus fracture, shaft of humerus fracture, supracondylar fracture. Okay, so most common mechanism of proximal humerus fracture is always fall on outstretched hand, push. Most common mechanism of shaft of humerus fracture is direct trauma. Patient is walking, falling down, direct hit over the shaft of the humerus by a stone or some hard article fracture. Most common artery that is damaged in proximal humerus fracture is axillary artery. Most common artery that is injured in shaft of humerus fracture is brachial artery. Most common nerve that is injured in proximal humerus fracture is axillary nerve. Axillary nerve. Most common nerve that is damaged in shaft of humerus fracture is radial nerve. These are very basic questions, very important. Now let us see about proximal humerus fracture. You see, proximal humerus consists of the following part. A greater tuberosity, lesser tuberosity, head, shaft and two necks. You see here, This is the head. Okay. This is the greater tuberosity. This is the lesser tuberosity. This is the humeral shaft. Okay, an area which is between the whole thing and the starting of this metaphyseal area, this is called surgical neck. This is called surgical neck, and this is called anatomical neck. These are very basics. When fracture is happening in the surgical neck, many patients are going for non-union. If it happens in anatomical neck, many patients are going for avascular necrosis, head of the humerus. So this is very important. Only when we know the parts very carefully, we can go for the classification, which is called Neer's classification, which depends upon the parts. Okay, so a greater tuberosity, a lesser tuberosity, head of humerus, and then surgical shaft. Okay, so these are the four. This proximal humerus fracture is very most common in postmenopausal women because of osteoporosis. So most of the time, proximal humerus fracture is a pathological fracture. When will you call a part is displaced? I told you head, greater tuberosity, lesser tuberosity, shaft. So fracture is happening between these parts. When will you say the part is displaced? When the displacement is more than 1 centimeter. This is a criteria, dear friends. You should remember. Okay, you should remember. Only with this they are framing many questions. When the displacement is more than 1 centimeter between the parts and or the angulation more than 45 degree, then that part is said to be displaced. It needs some mention. Okay, undisplaced fracture, displaced fracture. How can we say in proximal humerus? When the displacement is more than 1 centimeter or angulation more than 45 degrees. With this, just we will see what is Neer's classification. 1 lakh time repeated MCQ, very, very important in our NEET PG. It is divided into 4 parts. 1 part, 2 parts, 3 parts, 4 parts fracture. Only when you classify what type of proximal humerus fracture, you can fix the treatment, because the treatment is totally different for all the 4 types. 1 part fracture means fracture line involves one of the 4 parts. Fracture line involves one of the 4 parts. No part is displaced. You see here, a fracture line goes here, but the displacement is less than 1 centimeter, angulation is less than 45 degree. So this is called 1 part fracture. Here, fracture line involves one of the 4 parts, no part is displaced. This is called Neer's 1 part fracture. Treatment totally different. That I will tell it in the next page. Now, what do you mean by 2 parts? Neer's 2 part fracture. What do you mean by that? Fracture line involves 2 of the 4 parts. 1 part is displaced. You see here the greater tuberosity is totally displaced. It is totally displaced. This is called 2 part fracture. 3 part fracture means fracture line involves 3 of the 4 parts. What are the 4 parts? Greater tuberosity, lesser tuberosity, head, shaft. These are the 4 parts. I told in the very beginning. You forget about these 2 necks. Surgical neck and anatomical neck, you forget. What are the 4 parts? Greater tuberosity, lesser tuberosity, head, shaft. 4 parts. When a fracture line involves 3 parts, 3 out of 4 parts, and 2 parts are displaced, that is called a 3 part fracture. Look at this diagram. 1, 2, 3, 4. 3 parts are involved, 2 parts are displaced. Okay, this is called a 3 part fracture. Neer's 3 part fracture. What do you mean by Neer's 4 part? Fracture line involves all the 4 parts and 3 parts are displaced. See, fracture line is involving 1 part, 2 part, 3 part, and this is the 4 part. Greater tuberosity, lesser tuberosity, head and shaft. It's involving fracture line involving 4 parts. 3 parts are displaced. 1, 2, 3, totally displaced. Okay, so this is called a Neer's 4 part fracture. Worst prognosis. Okay, so 1 part fracture has the best prognosis. 4 part fracture has the worst prognosis, because invariably 4 part fracture will go for avascular necrosis. It's not going to unite. It will go for avascular necrosis. Now, coming to treatment. If it is Neer's type 1, what is Neer's type 1? Fracture line involves 1 part, okay, and no part is displaced. That is called NIRS type 1. Treatment of choice is conservative. Don't do any surgery. Most fractures are undisplaced and impacted. So treat it with a triangular arm sling and a Whelpway bandage. This is called Whelpway bandage. This is the treatment of choice for NIRS type 1. How many times they had asked this MCQ? Then NIRS type 2. NIRS type 2. What is NIRS type 2? Fracture line involves 2 of the 4 part and 1 part is displaced. This is NIRS type 2. So you just analyze which part is displaced. You just analyze which part is displaced. Okay. You come here. You just see NIRS type 2. If surgical neck is displaced, closed reduction and arm sling or K-wire fixation. If greater tuberosity is displaced, mostly greater tuberosity displacement is associated with shoulder dislocation, so that may require open reduction internal fixation. Greater tuberosity is attached to 3 tendons. It's called supraspinatus, infraspinatus, teres minor. It's called SIT, that is the mnemonic. Supraspinatus, infraspinatus and teres minor. These are the 3 tendons that are attached to greater tuberosity. So, great avulsion happens. So, most of the time, it may, even though it is type 2, it may need open reduction internal fixation, some K-wire, some procedure may be needed. If it is type 3, NIRS type 3, okay, fracture line involves 3 areas, and there are displacements in 2 areas, that is called NIRS type 3. The treatment of choice is open reduction internal fixation with Philo's plate. Look at the diagram. Philo's plate. Philo's is a abbreviation. Philo stands for proximal humerus interlocking system. Okay, all the first letters they have taken P-H-I-L-O-S. Philos. Philos stands for proximal humerus interlocking system. So it's a plate, open reduction internal fixation. It's a special plate. Okay, so that is the treatment of choice for NIRS type 3. If it is NIRS type 4, highly prone for avascular necrosis, so you have to go for shoulder replacement. Arthroplasty is the treatment of choice. So NIRS type 1 conservative, NIRS type 2 sometimes needs open reduction internal fixation with K-wire or something. NIRS type 3 definitely open reduction internal fixation with Philo's plate. NIRS type 4 replacement arthroplasty, shoulder replacement arthroplasty. That's the treatment of choice. Coming to complications of proximal humerus fracture, the dreaded complication is avascular necrosis. The most common nerve that is involved is axillary nerve. Second common nerve that is involved is suprascapular nerve. Very important. Campbell. This is from Campbell. Third important complication is non-union of surgical neck. Fourth important complication is fracture dislocation. I told you in 2-part fracture, especially if greater tuberosity is avulsed, mostly that will be associated with shoulder dislocation. Myositis ossificans, like your elbow dislocation, or proximal humerus near a joint, so more prone for myositis ossificans. It can go for malunion, joint stiffness, very common complication, whatever the type of proximal humerus fracture. The most common complication is joint stiffness. Even though I typed this in the 7th position, that's the most common complication. The dreaded complication is avascular necrosis. Okay, yes. Now coming to shaft of humerus fracture, the treatment of shaft of, I said that mechanism is direct hit. The coming to management, no, if it is a conservative management, the best cast that is given, in conservative management, if you want to apply plaster of Paris for proximal humerus, that's called U-slab. That's called U-slab. If it is shaft of humerus fracture, it's called hanging arm cast. It's called, look at this diagram. So shaft fracture somewhere here. So at the level of insertion of the deltoid, I am starting a POP cast. It comes up to the wrist like this. This is called a hanging arm cast. That's called a hanging arm cast. That's called hanging arm cast. That's the best management, conservative management for shaft of humerus fracture. If at all surgery is needed for shaft of humerus fracture, the best management is open reduction internal fixation with plates. Okay, plates. But with that, the surgeon should be a real expert, otherwise very high chance of radial nerve injury. Another closed method is just you are putting a drill in the head of the humerus, introducing a nail inside and locking the proximal fragment and locking the distal fragment. This is called intramedullary interlocking nail. Other is called Russell-Taylor's nail. The nail is called Russell-Taylor, T-A-Y-L-O-R, Russell-Taylor's nailing. Okay, this is one new concept in treating the shaft of humerus. So, shaft of humerus fracture can be treated by two ways: open reduction internal fixation with plate and screws, a time-honored method. Otherwise, you can do what is called an intramedullary interlocking nail. Okay, and the nail is called Russell-Taylor's RT nail, Russell-Taylor's nail. And especially, book says that when will you do nailing? I can do nailing in pathological fractures. I can do nailing in pathological fractures. Right. So, nailing is superior to plating. That's the concept. A very osteoporotic bone or pathological fractures, nailing is superior to plating. This was once an asked question. Yes. So, after that, in humerus fracture, repeatedly asked question, you should know what is Holstein-Lewis fracture, named fracture. What is Holstein-Lewis fracture? It is fracture distal third shaft of humerus, not the middle third, distal third shaft of humerus at this area. Fracture pattern can be either oblique or spiral, The distal fragment is mostly shifted, always shifted towards the radial side. It is shifted towards the radial side. Highest chance of radial nerve injury. Very high chance of radial nerve injury. What is the significance of Holstein-Lewis fracture? It is a fracture distal third shaft of humerus which is oblique or spiral in nature. The distal fragment is shifted towards the radial side, so very high chance of radial nerve injury. Most of the Holstein-Lewis fracture will be associated with radial nerve injury, so that becomes an orthopedic emergency. You can't manage Holstein-Lewis fracture conservatively. It should be opened, the radial nerve should be explored. If there is compression, it should be decompressed, then fixed with plate and screws. That's the management. To some extent, we have completed the topic, proximal humerus and shaft of humerus fracture. Okay, dear friends, we'll move on to another very important topic, supracondylar fracture. Very thoroughly discussed in our main recording. Just this is a rapid revision. Introduction. Most common fracture in the childhood. Most common fracture of newborn is clavicle. Most common fracture of children under 10 years, supracondylar fracture. Most common fracture requiring surgery in children is supracondylar fracture. Peak age is 5 to 6 years, more common in boys because boys very playful. History of fall more common in boys and more common on left side. Okay? Yes. Now, why this supracondylar fracture is common less than 10 years? Because you know pretty well medial epicondyle, lateral epicondyle, the area above is called supracondylar area, which is a metaphyseal area, which is constantly remodeling. Remodeling area is always weak. So, whenever a child falls on outstretched hand, supracondylar fracture, that's the most common vulnerable area below 10 years. Then, the humerus, when you take an adult humerus, the cut section is cylindrical. Okay, in a child below 10 years, the humerus cut section is flat. Okay, so it's not cylindrical like our adult humerus is like a cylindrical pipe, whereas humerus, cut section of humerus below 10 years in a child is flat pipe. So, which is easily bendable, cylinder or a flat pipe is easily bendable. So, easily bendable, that metaphyseal area is already weak, so tuck, it will go for fracture. Metaphysis is just distal to two fossae. Fossae means empty space. Two fossae. What are they? Coronoid fossa and radial fossa. So, already two holes are there. Okay, vacant spaces are there. The supracondylar area very near to it, so easily breakable. Right? So, these are the reasons why supracondylar fracture is more common in children less than 10 years. Right? Mechanism of injury, most common mechanism is fall on outstretched hand with the elbow in full extension. That's the point. Fall on outstretched hand alone is not enough. In full extension. That's why extension type of supracondylar fracture is the most common type. The common displacements of supracondylar fracture, the mnemonic which we use is called DIM mnemonic. For Colles fracture, it is Dill's mnemonic. It will come. For supracondylar fracture, it's called DIM mnemonic. Whenever a fracture has happened, it should have two fragments, proximal fragment and distal fragment. Where is the position of the distal fragment? That determines the type of supracondylar fracture. Okay, that determines the type of supracondylar fracture. See, you look at this X-ray, this whole chunk, no, this is the distal end of the humerus. This is the proximal fragment. The small chunk here, okay, this is the distal fragment. Where is the distal fragment, or how is the displacement of the distal fragment determines which type of supracondylar fracture. The commonest type, I said, it is extension type, 98% extension type. What are the displacements? The distal fragment is displaced dorsally. Impaction of distal fragment into the proximal fragment. Medial tilt or medial shift of the distal fragment. Dorsal displacement, impaction, medial tilt, DIM mnemonic. This is the commonest type, 98%. Very rarely the distal fragment is shifted volar aspect. Then this is called flexion type. It is only 2%. Remember, there are two types of supracondylar fracture, an extension type and a flexion type. When the distal fragment is shifted dorsally, that is called the extension type, which is 98%. 98%. When the distal fragment is shifted volarly and the flexor aspect, that is only 2%, very rarest type. Okay. So, there is a classification for extension type of supracondylar fracture is divided into two, posteromedial, posterolateral. Posteromedial, the distal fragment is shifted dorsally in both the types. When there is the dorsal displacement is associated with posteromedial shift, this is the most common type, 80%. When the dorsal fragment is shifted laterally, posterolateral shift, that is 20%. So, extension type is divided into posteromedial, posterolateral. Okay. Even though 80% it's there, whenever in posteromedial, the nerve at risk is radial nerve. You should be very careful. This is a tricky area. Please be very careful. See, posteromedial type, the nerve at risk is radial nerve. Posterolateral type, the nerve at risk is anterior interosseous nerve. But the book says posterolateral type is associated with more nerve injury than posteromedial type. So, the most common nerve that is damaged in supracondylar fracture, without doubt, from Chapman and Campbell, anterior interosseous nerve. The most common nerve that is injured is anterior interosseous nerve. Next to anterior interosseous nerve is your radial nerve. Okay, so the most common nerve is always anterior interosseous nerve. Yes. Now, coming to classification system of supracondylar fracture, time-honored MCQ in most of our NEET entrance, type 1, type 2, type 3, and this is called Gartland's classification. Type 1, just a fracture line goes through this, but is totally undisplaced. Type 2, partially displaced. What is the meaning? When you see here, the anterior cortex is open, posterior cortex is intact. I rub this, you just see, this is open, this is posterior cortex is intact. This is anterior cortex, this is posterior cortex. Anterior cortex is open, posterior cortex is intact. This is called Gartland's type 2. Gartland's type 3, completely displaced. You see, totally there is total distraction, displacement of the proximal fragment and distal fragment, big gap between them. Then it is called Gartland's type 3. Because only when we classify a fracture, we can plan the management. Okay? Yes. Now coming to clinical feature of supracondylar fracture, make the baby sit in a stool, look the baby from the side, the lateral aspect. The arm appears S-shaped. Look at here, an S-shaped arm. Number 1. Number 2, since the proximal fragment comes and buttresses or pierces the brachialis muscle, over the skin you can see a dimple-like thing, a puckering here, a dimple-like thing. This is called dimple sign. This is called dimple sign. Okay. An S-shaped arm. S-shaped arm and a dimple sign plus a dimple sign. Two clinical signs of supracondylar fractures are S-shaped arm and a dimple sign. And you should be very confident these classical deformity and dimple sign occurs only in Gartland's type 3. Type 1 is undisplaced. In undisplaced fracture, you cannot expect a deformity, dear friends. So, only in completely displaced type, in type 3, you can expect this deformity. The next important thing always, whenever you come across a supracondylar fracture, you should be able to differentiate that from elbow dislocations. So, supracondylar fracture is happening above medial and lateral epicondyle. So, the three bony points are not disturbed. Medial epicondyle, lateral epicondyle, olecranon on tip gives an isosceles triangle or equilateral triangle. The triangle is not at all disturbed in supracondylar fracture. Three bony prominence, the triangle is very much disturbed in elbow dislocation. This is how to differentiate an elbow dislocation from supracondylar fracture. Three bony point relationship. Three bony point relationship is not disturbed in supracondylar fracture. Three bony point relationship is very much disturbed in elbow dislocation. Okay, that's all. Then coming to X-ray signs, there are 5 classical X-ray signs. Number 1, fat pad sign. All the X-ray signs, elbow joint lateral view is taken. All the classical X-ray signs of supracondylar fracture, the view is lateral view. In lateral view, you can see this is the fracture line. Just you can see here a gaseous shadow in anterior and posterior aspect. You zoom your app and see. This is called anterior fat pad sign. Anterior fat pad sign. It is called fat pad, anterior fat pad sign. Here it is called posterior fat pad sign. Okay, posterior fat pad sign. Okay, so you can see in the lateral view of the X-ray, you can see a gaseous shadow in the muscle, which is called fat pad sign. Okay, so what is the significance of this sign? See, sometimes if it's a very minute hairline crack of supracondylar fracture, however good quality of the X-ray, however good an orthopedician, we may not see the fracture line. But when fat pad, anterior and posterior fat pad sign is positive, you consider that is a case of supracondylar fracture. So, my professor used to teach us very practically, fat pad sign is a 100% positive sign in case of supracondylar fracture. Very reliable sign. They may frame an MCQ like that. So, fat pad sign is very important. What is the second radiological sign? In detailed fashion, already I had discussed in our main recording. This is just a quick revision. So, I am going fastly. You see, teardrop sign. Again, when you take a lateral view, teardrop sign of elbow is normal. It is normally present in all of us. What is that? You take an X-ray of the lateral view of the elbow. This is the capitulum. This is the lower portion of the humerus. This is the capitulum. This is schematic diagram. This is the schematic representation. Is it not looking like this is a real X-ray? You see the real X-ray? I am seeing here this capitulum. Is this not? I will erase this now. You just concentrate. You just see. Is this not looking like a teardrop? So, teardrop sign is a normal sign of lateral view of the elbow joint in all of us. What happens in supracondylar fracture? Whenever a fracture happens, supracondylar, this should be the area. A fracture line crosses this teardrop. Fracture line crosses this teardrop. So, the correct explanation, teardrop sign is disturbed in supracondylar fracture. Teardrop sign is disturbed in supracondylar fracture. The second radiological sign is over. Third radiological sign, you again take a lateral view X-ray of the elbow joint. Look at this. When you draw a straight line in anterior aspect of the humerus, this goes and cuts the center of the capitulum. This is your capitulum, dear friends. Okay, now I am erasing. You just see. Whenever I draw a white line, straight line on anterior aspect of the humerus, this goes and cuts center of the capitulum. That is normal. That is normal. When supracondylar fracture happens, when I draw a line on the anterior aspect of the humerus, it is no way near the capitulum. You see the capitulum is here, but it's nowhere near the capitulum. Then it's called anterior humeral line, not cutting the capitulum. It is seen in supracondylar fracture. Supracondylar fracture, anterior humeral line, very important in assessing a supracondylar fracture. Third sign is over. Fourth sign, the full name is Marion crescent sign. Most of the undergraduate textbooks uses the word crescent sign. The full name is Marion crescent sign. Normally, this is a normal X-ray lateral view of the elbow. This is capitulum. This is olecranon. This is olecranon. This is the capitulum. Olecranon is a part of ulna bone. Capitulum is part of lower end of humerus. Whenever normal X-ray, there is a gap, joint space is seen between the capitulum and the olecranon. This is normal. A radiolucent gap is seen. That is normal. If supracondylar fracture has happened, there is a opacity here, that radiolucent gap, the joint line is missing. I am able to see like a crescent-like shadow. That is because of overlap of olecranon over the capitulum. There is overlapping of the olecranon over the capitulum. So, normal joint line is missing. You can't see the normal joint line. Instead of that, on the lateral view, you are seeing like a moon. That's why it's called crescent. Okay, which is come Luna, moon. Okay, so exactly like a moon. Okay, that we'll say the third day after no moon day, we'll see that's called a crescent. Okay, so the radiolucent gap is missing. Instead of that, you are seeing a radio opaque moon-shaped shadow because of overlap of the olecranon over the capitulum, and that is called Marion's crescent sign, fourth radiological sign. Last but not the least, when you take an X-ray, the proximal, this big thing is the proximal fragment, the small chunk, this is the distal fragment. Okay, you see here, the proximal fragment, the distal end of the proximal fragment is serrated like a fishtail. So, this is called the classical fishtail sign in case of supracondylar fracture. This fishtail sign is seen in Gartland's type 3. In Gartland's type 3, it should be completely displaced. Then only you can assess the fishtail sign. So, 5 radiological signs of supracondylar fracture. Dear friends, anterior posterior fat pad sign, teardrop sign disturbed, anterior humeral line, Marion crescent sign, fishtail sign. Okay? Yes. Now coming to treatment, management of supracondylar fracture. Type 1 Gartland, I said, undisplaced. Treatment of choice is immobilization in a long arm cast at 60 to 100 degree flexion. When you hyperflex, the triceps will act like a splint. It will compress the fracture. The fracture will heal very neatly. It's indicated for 2 to 3 weeks. Okay. So, type 1 management is conservative. Type 2, closed reduction, because type 2 posterior cortex is intact, anterior cortex is open. So, just to close it with a C-arm control, you do a closed reduction with percutaneous cross K-wires. Put a K-wire like this, closed. If it is type 3, totally displaced, you have to put a posterior incision, open the triceps, reduce the fragments, pakka reduction of both the proximal and distal fragments. There should not be any medial or lateral tilt, because whenever there is some medial tilt, the tilt is also not corrected. It will go for cubitus varus. So, pakka anatomical reduction, then fixing with the cross K-wires like this. Cross K-wire fixation like this. Excellent result. This will unite very easily because that's a cancellous area. So, healing is very quicker. Perfect anatomical reduction is what is expected. So, type 1 conservative, type 2 closed reduction internal fixation, type 3 open reduction internal fixation. Coming to complications of supracondylar fracture, the most common nerve that is involved is anterior interosseous nerve. Second common is radial. Most common vessel that is damaged is brachial artery. Most common late complication is malunion, and that is called cubitus varus. Cubitus varus. Otherwise, that is called gunstock deformity. Gunstock deformity. This is that cubitus varus, exactly looking like a gunstock. Okay, it's called gunstock deformity. That's the most common late complication. Since it's an elbow joint, okay, tight bandaging and all cause compartment syndrome. That is called Volkmann's ischemia, and is more prone for myositis when it goes for a traditional bone setters, myositis ossificans. All are asked question. We can't leave a single point. Then special point for our guys, prep ladder guys, special points. What is Mettau sign? So far unasked in any of our Indian entrants, dear friends. This is a radiological sign of supracondylar fracture. Supracondylar fracture, you know pretty well, when it undergo traditional bone setters, more prone for myositis ossificans. Myositis mass has happened here. Okay, X-ray, you can see a myositis mass as a radio-opaque thing in the elbow. Okay, a thick nerve which is here is a median nerve. When the median nerve pierces the myositis mass, the piercing area by the median nerve is not opaque. So you are seeing, for example, this as this area median nerve is piercing. Okay, this area median nerve is piercing. Okay. Right? What happens, you see? Alright, you see, all other areas, it is radio opaque. It has become radio opaque. Okay, center portion is black in color. Okay, all other areas, that yellow color is radio opaque. Okay, like this. X-ray, it will appear like this. Okay, you see here. The center area which is black, the center area which is black is radiolucent area in the X-ray. That is the area pierced by our median nerve. This sign in X-ray is called Mettau sign. So far unasked in any of the Indian entrants. So Mettau sign is seen in case of supracondylar fracture treated traditionally by traditional bone setters. Myositis mass has developed. Radial nerve piercing the myositis mass will appear like a radiolucent hole, okay, in between the radio-opaque area. That is called Mettau sign. It's a radiological sign. Okay. Now, let us see about lateral condyle fracture. When we finish this lateral condyle fracture, fracture humerus is over. Lateral condyle fracture is otherwise called fracture of necessity. Fracture of necessity. Fracture of necessity. Fracture of necessity means 100% surgery is necessary. There are two fractures of necessity in orthopedics, dear friends. Number one, lateral condyle fracture of humerus in a child. Number two, because in child you won't operate unnecessarily. Yes or no? We won't keep knife because it's a growing bone. It may injure the epiphyseal growth plate and the patient can develop limb length discrepancies. So we won't operate normally. But if it is fracture lateral epicondyle, lateral condyle, 100% surgery is necessary. Otherwise, it will go for non-union. So this is called fracture of necessity. Another fracture of necessity in orthopedics is Galeazzi fracture, which will come under forearm fracture. That I will insist one more time there. Okay. So bookish definition, fracture of necessity, only two fractures. There is lateral condyle fracture of humerus. Another is Galeazzi fracture of the forearm in adults. One name, two synonyms are there for lateral condyle fracture. One is fracture of necessity. Another, this is called Jupiter fracture. This is called Jupiter. So far unasked in any of the Indian entrants. They'd ask what is Monteggia, what is Galeazzi, named fractures. Schaffer, many named fractures are there in upper limb. Jupiter fracture is lateral condyle fracture. It's otherwise called Jupiter, named after a very famous orthopedician, Jupiter. His name is Jupiter. So it's called Jupiter fracture. The lateral condyle epiphysis, otherwise called capitular epiphysis, begins to ossify during first year of life. Fuses with shaft by 12 to 16 years of life. This is for your general information. So the most common age group for this injury is 5 to 15 years. Lateral condyle humerus. Supracondylar fracture, we said that peak incidence is 5 to 6 and it's a fracture which happens below 10 years. Here the most common age of injury lateral condyle fracture is 5 to 15 years. The child falls on hand with elbow extended and forced into varus. Okay, elbow extended, forced into varus. So it's a varus type of injury. Now, the classification of lateral condyle fracture is called Milch classification. Only two types, type 1, type 2. Type 1, fracture line runs lateral to the trochlea. You all know this is trochlea. So lateral to the, this is trochlea. So lateral to the trochlea. So lateral to the trochlea into the capitulotrochlear groove. Elbow is stable. This is type 1. Type 2, fracture line runs into the apex of the trochlea. This is the trochlea. So fracture line apex of the trochlea. And elbow is unstable. So the most common type is type 2. Most common type of lateral condyle fracture. So far they have not asked this question. Concentrate. Okay. Milch. 3 bony point relationship. Medial epicondyle, lateral epicondyle, tip of the olecranon. In supracondylar fracture it is not disturbed. In elbow dislocation that is disturbed. Since this is involving the lateral epicondyle, definitely that should be disturbed because the intercondylar distance is increased between the medial epicondyle, lateral epicondyle should be more because fracture is there in the lateral epicondyle. X-ray will cheat us as it always shows a smaller fragment, lateral epicondyle, because it's a growing bone, no? So most of the fragments are cartilaginous. So in X-ray it appears very smaller. When you open, the cartilage appears bigger. It's a very technical point. Treatment is always open reduction internal fixation with K-wire. That is why this is called fracture of necessity. 100% surgery is necessary. So this is called fracture of necessity. Complications of lateral condyle fracture are very important. Lateral condylar spur. This is the most common complication. Overgrowth of the lateral epicondyle. Lateral condylar spur is the most common complication. So far unasked in any of our Indian entrants. Most common complication of supracondylar fracture, late complication, malunion, gunstock deformity, cubitus varus, 1 lakh time repeated. They have not asked this. Most common complication of lateral condylar fracture is overgrowth of the lateral condyle, which is called lateral condylar spur. Okay, most common late complication of lateral condylar fracture is non-union. Supracondylar fracture it is malunion, lateral condylar fracture it is non-union. It's very common complication because cubitus valgus is a common complication, right? As it involves the growth plate, every year the cubitus valgus worsens. This is valgus, this is varus. So it worsens. Slowly it starts stretching the ulnar nerve. So ulnar nerve will go for palsy, but it go very late. So it's called tardy ulnar palsy. How many times they had asked this question? As a progressive type of valgus, it causes stretching of the ulnar nerve. It takes years. So it's called tardy, means very slow. Tardy ulnar palsy. Okay. So treatment of cubitus valgus, treatment of cubitus varus. In case of supracondylar fracture, cubitus varus, against an osteotomy. That osteotomy is called French osteotomy. That's the treatment of choice. 2 types of osteotomy is available there. King's osteotomy, French osteotomy. French osteotomy is superior to King's osteotomy. Whereas the osteotomy to correct cubitus valgus is called Milch osteotomy. Only one osteotomy. So lateral condyle fracture, cubitus valgus best corrected by Milch osteotomy, cubitus varus best corrected by French osteotomy. 1 lakh time repeated question. Concentrate. And posterolateral instability of the elbow. Lateral condylar fracture always causes elbow instability. Supracondylar fracture will not cause elbow instability. Rarely cubitus valgus. That is not important. As usual, since it's around the elbow joint, myositis ospicans. So, dear friends, to some extent, we have completed the topic lateral condyle fracture. So, humerus fracture is over. Proximal humerus we have finished. Shaft of humerus we have finished. Supracondylar we have finished. Lateral condyle fracture we have finished. Okay, dear friends, we will move on to another very important short topic. Elbow dislocations. Okay. Elbow dislocation. Most common joint to be dislocated in children. Very, very tricky point, dear friends. Most common joint to be dislocated in the human body, if they ask without mentioning any age, shoulder dislocation. If they specifically ask most common joint to be dislocated in a child, it is not shoulder, it's elbow. Okay. Posterior dislocation of the elbow is the most common type. Okay. Clinical features. How many types of elbow dislocations are there? You see here, posterior, Anterior, you see here, when olecranon is pushed back, it's called posterior. When olecranon is at the front, it's called anterior. When olecranon is at the lateral, it's called lateral. When olecranon is at the medial, it's called medial. When totally there is divergence between the radius and the olecranon, the ulna, then it's called divergent. 5 types are there: posterior, anterior, lateral, medial, divergent. The most common type is always posterior. Most common type is always posterior. After posterior, some books are telling posterolateral, posterior will be there, mild lateral shift will be there. This combination is the most common type. This is higher books, MS Ortho level. For our PG entrance, the most common type of elbow dislocation is posterior. Okay. Then coming to clinical manifestations, very importantly, the forearm, I said in supracondylar fracture, there is S-shaped arm. In elbow dislocations, because most common type is posterior, the olecranon is pushed backwards. What happened? The forearm on the affected side appears shorter. This forearm looks normal. Affected side appears shorter. This is the first sign. Second sign, obviously elbow, the patient can't flex and extend. That's okay. Apart from that, the very important thing, as I said, the 3 bony prominences: medial epicondyle, lateral epicondyle, medial epicondyle, lateral epicondyle, tip of olecranon. In supracondylar fracture, this equilateral triangle is well maintained. Okay, in supracondylar fracture. In elbow dislocation, the triangle is disturbed. This is a very important sign. And the third important thing is, since the olecranon is pushed backward, the triceps tendon, normally the tight triceps tendons becomes lax and it stands out prominently. The triceps tendon stands out. When you see from lateral, there is bulging of the triceps tendon. Triceps tendon stands out prominently. That is called bowstring sign. That's called bowstring sign. So 3 classical signs of clinical signs of elbow dislocation. Forearm appears shorter, 3 bony prominences disturbed, bowstring sign. Okay, yes. The types of elbow dislocation already we have discussed. What are the components of terrible triad of elbow? This terrible triad of elbow goes by a name Hotchkiss triad. Okay, elbow, the unhappy triad of elbow or terrible triad of elbow is otherwise called Hotchkiss triad. What are the 3 components? Number 1, posterior dislocation of elbow. Posterior dislocation of elbow plus radial head fracture. Plus coronoid fracture. This combination is called terrible triad of elbow, otherwise called Hotchkiss triad or unhappy triad. So there are 3 terrible triads in orthopedics, dear friends. Terrible triad of shoulder doesn't have any name. That is shoulder dislocation plus anter-shoulder dislocation. In the shoulder dislocation, whenever the patient is having a Bankhart's lesion plus a Hill-Sachs lesion plus erosion of the anterior glenoid rim, that is called terrible triad of shoulder. When there is posterior dislocation plus coronoid fracture plus radial head fracture, that is called terrible triad of elbow. Another terrible triad in the knee joint, that is anterocruciate ligament injury plus medial meniscal injury plus medial collateral ligament injury, is called unhappy triad of knee or terrible triad of knee of, and it goes by a name, a Dutch surgeon's name, O'Donoghue. Okay, O'Donoghue. Okay, that's the correct pronunciation, O'Donoghue. I will teach that when we deal with sports injury. Okay, yes. So this is the terrible triad. Yes. Now coming to treatment, reduction under general anesthesia with the above elbow POP slab and immobilization for minimum of 3 weeks. And the complications, the most common vessel that is damaged in elbow dislocation is brachial artery. Most common nerve that is damaged in elbow dislocation is median nerve. Very, very important. Most common nerve that is damaged in supracondylar fracture is anterior interosseous branch of median, not median directly. In elbow dislocation, the most common nerve that is damaged is directly the median nerve. This is the catchy point. Now, you should know pulled elbow. Very, very frequently asked question. This is otherwise called nursemaid elbow, pulled elbow. in an extended and pronated forearm. When the forearm is extended and this is supination, pronated forearm, when the elbow is pulled in a child, the radial head gets subluxated and comes out of the annular ligament with a snappy sound. That is called pulled elbow. That is called nursemaid elbow. When you suddenly pull the baby, when you want to carry the baby and when you want to just lift the baby, you should lift from the shoulders like this. You should not lift like this. That will cause pulled elbow. Very, very common problem. Most common age, this is a question 1 lakh time repeated, 1 to 4 years. Rare after 5 years. It's called pulled elbow. Okay, slippage of radial head from the annular ligament due to sudden pull in a child age between 1 to 4 years. A snappy sound will be heard. That's called a pulled elbow. And coming to this is a general thing. This may be helpful for you in anatomy, orthopedics, and forensic medicine. Forensic medicine, age estimation. Okay, around the elbow. Okay, mnemonic is called Crittall mnemonic. Appearance of epiphyseal centers around the elbow. Okay. Capitulum, Crittall stands for capitulum, radial head, epicondyle medial, trochlea, olecranon, lateral epicondyle. Crittall mnemonic. Okay, very easy. 2, 4, 6, 8, 10, 12. Write like this. In your rough paper, it work like this so that easily. So, you see capitulum, radial head, epicondyle medial, trochlea, olecranon, lateral epicondyle, in that order. Appearance of epiphyseal center. This is for our just general teaching. Okay. To some extent, dear friends, we have completed the topic elbow dislocations. Okay, dear friends, we will move on to another very short topic, Monteggia's fracture. What is Monteggia's fracture? Definition. It is fracture upper third ulna with radial head subluxation. It is fracture upper third ulna, you see, fracture upper third ulna with radial head subluxation. This is called Monteggia. It is due to fall on outstretched hand in hyperpronated forearm. So it is fall on outstretched hand in, this is supination, this is hyperpronated forearm. And overall, this is more common in children than adults. They are comparing this with Galeazzi fracture. So when compared with this is overall more common in children. Monteggia is more common in children. The classification system for Monteggia's fracture is called Bado's classification. 4 types are there, type 1, type 2, type 3, type 4. Type 1, it's called extension type, and this is the most common type. This is the most common type. What is type 1? You look at this diagram. Fracture per third ulna, no? The angulation of the fracture is anterior angulation, and dislocation of radial head is also anterior. Okay, so when you see an X-ray lateral view, when there is anterior angulation of the fracture and dislocation of radial head which is shifted anteriorly, then that is called type 1 Bado, which is the most common type, more common in children. Type 2, which is called extension type, very less, 5%. What is that? The exact opposite to that. You see, fracture angulation is posterior and dislocation of radial head is also posterior. When posterior dislocation of radial head with posterior angulation of the fracture, it is called type 2. It's called flexion type, more common in adults. Okay. Type 3, lateral dislocation of the radial head exclusively in children. The fracture is there and lateral dislocation exclusively in children. Type 4, anterior dislocation of the head of the radius with fracture of both radius and ulna. This is very rarest type, exclusively in adults. You see here, there is dislocation of radial head and fracture both bone forearm. Okay, proximal third. This is very rare. This is called Bado's type 4. Right. And usually book says this is a Monteggia variant. Okay. Most common nerve that is injured is posterior interosseous nerve and radial nerve. So the most common nerve is posterior interosseous nerve, which is a branch of radial nerve. Overall nerve injury is common in type 2. Okay. In second type. Okay. Type 2. Right. Type 2. And while taking this Monteggia's fracture is otherwise called treacherous fracture. Treacher means cheater. Treacherous fracture means cheating fracture. Why? Because this is fracture upper third ulna. Anybody can diagnose with an X-ray. Many times the radial head subluxation will cheat us. That's why it's called a cheating fracture or treacherous fracture. To overcome this, when we follow what is called this McLaulin's line, this fracture no more can cheat us. What is this McLaulin's line? Very simple. A straight fracture is in the ulna. Dear friends, fracture is there in the ulna. What is this McLaughlin's line? A straight line drawn along the shaft of the radius should go and cut capitulum in the center irrespective of position of the elbow. Okay, because radial head subluxation is happening. Yes or no? So when you draw a line along shaft of the radius, this should go and cut capitulum of the humerus irrespective of position of the elbow. If it doesn't cut the capitulum, it says radial head has slipped. This is called McLaughlin's line. Very, very practical way to diagnose radial head subluxation. Very, very important. Then coming to treatment, there is no hard and fast rule. In a case of child with Monteggia fracture, conservative closed reduction is the treatment of choice. You can do closed reduction and above elbow plaster of Paris, above elbow POP. That's the AEPOP, above elbow POP is the treatment of choice in children. In adults, open reduction internal fixation with plate and screw. Asian. This plate is called the Asian dynamic compression plate. DCP. Asian DCP is the treatment of choice. So children conservative, adult surgery. Coming to complications of Monteggia's fracture, unreduced dislocation radial head is the very troublesome common complication. Posterior interosseous nerve palsy, most common nerve that is involved. Malunion of the ulna. Non-union of the ulna. Cubitus valgus. Radio-ulnar synostosis. Myositis ossificans. See, these are the complications. Unreduced dislocation of radial head, posterior interosseous nerve palsy, malunion of the ulna, non-union of the ulna, cubitus valgus, radio-ulnar synostosis. Since it's around the radial head, subluxation is there around the elbow joint, myositis ossificans. So these are the complications. We'll move on to the next fracture, which is called Galeazzi fracture. What is Galeazzi fracture? Fracture lower third radius with distal radio-ulnar joint subluxation. Exact opposite to Monteggia. What is Galeazzi? Fracture lower third radius with distal radio-ulnar joint disruption or subluxation. That's called Galeazzi fracture. There are three synonyms. It's called Piedmont's fracture. This other is called fracture of necessity. Already I had told you in main session, very detailed discussion I had done in the rapid revision also. I meant when we were discussing about lateral condyle fracture, I said this is called fracture of necessity. There are two fractures of necessity in orthopedics. One is lateral condyle fracture in a child. Another is Galeazzi fracture. Galeazzi fracture, 100% surgery is needed. So it's called 100% surgery is necessary. So it's called fracture of necessity. This is other is called Monteggia's fracture. Three names are there. You look at here, proximal third ulna with radial head subluxation. This is called Monteggia. Distal third radius with distal radio-ulnar subluxation. This is called Galeazzi. Okay. Every year asked a question in image based and in clinical based questions. Clinical feature, prominence and tenderness over the lower end of the ulna is the classical feature. Okay. Distal radio-ulnar joint subluxation is there. So the styloid process, the ulna becomes prominent. When you just press over the ulna, distal end of the ulna is ballotable. Okay. It is movable, ballotable and very painful. Okay. What is this classical sign called? This is called piano key sign. Okay. This is piano key sign. This sign is called the piano key sign because we had seen piano players and keyboard players playing keyboard. Just when you press the keyboard key or piano key, it will go down. When you push it, it will go down. When you release, it will come up. Like that, distal end of ulna, when you press, it will go down. When you release, it will come up. Ballotable ulna like a piano key or keyboard key. So this is called piano key sign. Okay. And it's 3 times more common in this is 3 times more common than Monteggia's fracture, and this is more common in adults. Galeazzi is more common in adults, Monteggia is more common in children. Coming to treatment, never try conservative management. No, the only treatment is open reduction internal fixation with long plate and screw is the treatment of choice. This plate, everyone knows, this is called Asian dynamic compression plate, Asian DCP. You see here, Asian dynamic compression plate. Yes. Then coming to complications of Galeazzi fracture, this is a controversial area. In main recording I had told that. So which is the most common nerve that is involved? Never bother about this. One book is telling ulnar nerve injury, Apley is telling ulnar nerve injury, Watson Jones says anterior interosseous branch of median nerve. So this is a controversial area, very detailed. I had discussed there. Just go through that. When without controversy, the most common tendon that is entrapped is extensor carpi ulnaris tendon. Extensor carpi ulnaris tendon, which is the most commonly entrapped tendon. Okay, extensor pollis is longest tendon in Colles fracture. Extensor carpi ulnaris tendon in case of your Galeazzi fracture. Okay, and so far what we have seen is called Galeazzi fracture. Galeazzi sign is entirely different. Galeazzi sign, just for recollection sake, I will tell you, this we had read in the topic congenital dislocation hip, other is called developmental dysplasia hip. Suspected baby is put on the table in supine position, flex both the hips to 90 degrees, flex both the knee joint to 90 degrees. Normally, the level of the knee joint should be equal. If it is a case of developmental dysplasia hip, one side the level of the knee joint will be lower, which is limb length discrepancy, that's dislocated hip. So this is called positive Galeazzi sign, other is called Alice test, or one and the same. Again, the topic DDH, I will discuss this once more. Yes. Going to the next fracture, Essex-Lopresti fracture. What is this? Is combination of your Galeazzi and Monteggia. What is that Essex-Lopresti fracture? Please concentrate. It is comminuted fracture radial head with distal radial nerve joint subluxation. Monteggia's fracture is fracture upper third ulna with radial head dislocation. Galeazzi fracture is fracture lower third radius with distal radial nerve joint subluxation. Essex-Lopresti is comminuted fracture radial head with distal radial nerve joint subluxation. It's combination of both, very rare. And many times they are not asked this question, so expected question. Wrist pain is the most sensitive sign. Best diagnosed by X-ray lateral view of the wrist. Treatment, no? If it is comminuted fracture of radial head, if it is just an isolated comminuted fracture radial head, there is no disruption of distal radial nerve joint. It's not Essex-Lopresti, just a pure comminuted fracture radial head. What's the best management? Excise the radial head. That's what we do. Comminuted fracture radial head, best treatment is excision of radial head. Nothing will happen. Okay. If it is Essex-Lopresti, apart from comminuted radial head fracture, you're having distal radial nerve joint disruption. So when I remove a part of radius, when I'm removing head of the radius, what happens to length of the radius? It's decreased. Length of the radius is decreased. So every time when I flex the elbow, the radius goes up. You get migrated proximally. When I extend, it comes down. When I flex, it goes up. This is called proximal migration of radius. That's a complication when you do simple excision of the radial head. So to prevent that, the length of the radius should be maintained. So excision of the radial head with silastic prosthetic replacement. Excision of radial head with prosthetic replacement of the radial head. That's the ideal treatment. That's the only treatment that's available for Essex-Lopresti fracture. Be cautious, Essex-Lopresti classification is entirely different. This comes under the classification system for calcaneal fracture. Yes, we'll move on to radial styloid fracture. Radial styloid fracture comes under distal radial fractures. Distal radial fractures are divided into radial styloid, Colles, Smith, volar Barton, dorsal Barton. 5 types of distal radial fractures are possible. What are they? This radial styloid fracture, other is called Schaffer's fracture. Colles fracture, reverse Colles, other is called Smith fracture, volar Barton, dorsal Barton. 5 fractures are possible in the distal radius. We are going to see the first, that is radial styloid fracture. Radial styloid fracture is otherwise called Schaffer's fracture. Everyone knows Schaffer is a driver. Just olden days before self-starter, what happens? There is no self-starter, so they have to go in front of the car. They put a rod. That's called handle. You have to, like a generator, they have to start the car like this. When they do like that, when the engine got started, it will give a backfire. It will come and hit the radial styloid. So repeatedly, olden days drivers are sustaining radial styloid. So that was referred to as Schaffers. It's historical importance. Nowadays, self-starter is there. No need to think about that. This was first demonstrated by the great Hutchinson. So it's called Hutchinson's fracture or backfire fracture. These are the synonyms. Coming to management of, if you look at this radial styloid, are you able to see here a radial styloid, a fracture line here? Okay, just erase, you see radial styloid fracture. What happens? No, the best management is fracture is best treated by closed reduction and below elbow POP cast. If it is very unstable, very much displaced, K-wire fixation and below elbow POP cast. K-wire fixation and below elbow. Just you fix this fragment through a K-wire like this, then a below elbow POP cast. Okay, that will get united nicely. Then coming to Barton's fracture. What is Barton's fracture? It is a vertical marginal intra-articular fracture of the distal radius. What is the difference between Barton and Colles? When the fracture is intra-articular, that's called Barton. When the fracture is extra-articular, that's called Colles. Distal radial fracture, which is extra-articular, is called Colles. Distal radial fracture, which is intra-articular, is called Barton. Both volar Barton, dorsal Barton, both are intra-articular. So it is vertical, marginal, intra-articular fracture of the lower end of the radius. When the chip is displaced dorsally, it is called dorsal Barton. When the chip is displaced in the volar aspect, in the flexor aspect, that is called volar Barton. Volar Barton is the commonest type, and volar Barton is called true Barton, or this is other is called volar Barton, this other is called classical Barton. This other is called classical Barton. This is the most among dorsal volar Barton is the most common type. It's called true Barton, other is called classical Barton. Coming to treatment of Barton's fracture, volar Barton fracture, surgery is the treatment of choice. Open reduction, internal fixation with T-buttress, anterior T-buttress plating. Okay, anterior T-buttress plating is the treatment of choice. This plate is called the Ellis plate. This plate is called Ellis plate. Okay, so this plate, T-buttress plate, usually the plate will be in the shape like this. Okay, exactly in the shape of distal radius. Holes will be here. So one hole here, one hole. So holes will be, this is called a T-buttress plate. Okay, volar Barton plate. Okay, every day, it's a very, very bread and butter case for an orthopedician. Very common case. Dorsal Barton closed reduction plus above elbow POP cast is the treatment of choice. Okay, to some extent, we have completed the topic, Barton's fracture. Okay, dear friends, we will move on to another very important topic, Colles fracture. What is Colles fracture? Colles fracture is not just a fracture, it's fracture dislocation of the distal radial nerve joint. The fracture occurs about 2.5 centimeter proximal to the carpal extremity. That means it is extra-articular. This is extra-articular. Okay, this is extra-articular. This was first demonstrated by the great Sir Abraham Colles, but he used to call this fracture as Potow's fracture, old name for Colles fracture. After demise of Sir Abraham Colles, we are calling this in memory of him, we are calling this as Colles fracture. Fracture happens in the corticomedullary junction and it's extra-articular, so it heals best with the conservative management, and it's the most common fracture of elderly. So we have discussed few most commons so far. Most common fracture of newborn, fracture clavicle. Most common fracture of childhood, supracondylar fracture. Most common fracture of young adults, scaphoid fracture. Most common fracture of elderly, Colles fracture. Coincidentally, all the most common fractures happens in the upper limb only. Okay, and most common mechanism of Colles fracture is fall on outstretched hand in full extension. So this is very important. Fall on outstretched hand, push in extension. This is very important in extension. Look at this diagram. Okay, so this happens in extension. That's the mechanism, right? And what are the 6 components of Colles? This is very important, dear friends. You have to double concentrate here, because the 6 components of Colles, like 3 components of supracondylar fracture, DIM was the mnemonic. Okay, dorsal displacement, impaction, medial tilt, we had seen in supracondylar fracture. Like that, there are 6 displacements in Colles fracture. Only when we understand the displacements, we can reduce it properly with the conservative management, because we all know the best management of Colles fracture is conservative. Best management of Colles fracture is conservative. So only when we know the displacements, we can correct the displacement and immobilize in the proper position. So what are the 6 displacements? All the displacements are in relationship to the distal fragment. In a fracture, proximal fragment will be there, distal fragment will be there. Here, all the components are in correspondence with the distal fragment. Okay, so the mnemonic is called DILS mnemonic. I have written on the side DILS mnemonic. First is called dorsal tilt. Next is called dorsal displacement. Third is called impaction. Fourth is called lateral tilt. Fifth is called lateral displacement. And the last one is called supination. Okay, so the 6 displacements of Colles fractures are dorsal tilt, dorsal displacement, impaction, lateral tilt, lateral displacement, supination. All these corresponds to the displacement of the distal fragment, okay? The mnemonic I used to remember is DILS, so that you won't forget, okay? Yes. Styloid process test is a very reliable clinical test to diagnose Colles fracture. Normally, when you palpate the radial styloid, you palpate the ulnar styloid. Radial styloid in all of us 1.3 centimeter distal to the ulnar styloid. This is normal anatomy. If Colles fracture happens, both radial styloid and ulnar styloid will be at the same level. Okay, will be at the same level. Okay, so this is the most reliable clinical sign. The classical displacement of Colles fracture, we'll look at here. This is the distal fragment which is shifted dorsally. Okay, concentrate here. The distal fragment is shifted dorsally like a dinner fork. So the classical deformity of Colles fracture is called a dinner fork deformity. Okay, 1 lakh time repeated MCQ. Dinner fork deformity. Okay, dinner fork deformity. Then comes treatment of Colles fracture. Essentially conservative, like your fracture clavicle, this is essentially conservative. So what is that? So I am going to give a below elbow POP cast, okay, in close reduction, below elbow POP cast in full pronation, okay, in full pronation with palmar flexion, you see palmar flexion and ulnar deviation, palmar flexion and ulnar deviation. You see, put the patient whenever, please concentrate, just 1 minute. Whenever a fracture comes, first thing we will reduce. Reduction means we give traction. When I give traction, impaction, it was there, you see. You go back to your DILS mnemonic. Impaction is reduced. Impaction is neutralized when I give traction. After that, putting in full pronation, this is supination. I'm putting in full pronation. I'm turning the forearm to full pronation. That neutralizes supination, second displacement. Putting in full palmar flexion, that neutralizes dorsal tilt and dorsal displacement. Ulnar deviation, that neutralizes lateral tilt and lateral displacement. All the 6 displacements of Colles fracture is neutralized with your classical Colles cast. Okay, this is called Colles cast. This classical cast is called Colles cast. Okay, Colles cast. You see, below elbow POP cast in full pronation, palmar flexion, ulnar deviation for a period of 6 weeks. And whenever in full pronation, palmar flexion, ulnar deviation, this position is called cotton loaders position. Cotton loaders position. Okay, this is called cotton loaders position. For 6 weeks, it will heal excellently because this is happening in corticocancellous area, which easily it will form a callus and it will heal, and it's extra articular. So no need for surgery in Colles fracture. Yes. Then coming to complications of Colles fracture, the most common complication is stiffness of finger. Second common complication is malunion. Okay, and classically that will end up in dinner fork deformity. Okay, Alright? Deformity. Most common nerve that is damaged is median nerve. Because pretty well, dear friends, one of the important causes for carpal tunnel syndrome is malunited Colles fracture. We have read many causes for carpal tunnel syndrome like rheumatoid arthritis, compound palmar ganglion, pregnancy, menopause, hypothyroidism, that is myxedema, acromegaly. A list of causes are there. In that, a very important practical cause is a malunited Colles fracture, because malunited Colles fracture will compress the median nerve in the carpal tunnel, and that's called carpal tunnel syndrome. The most common tendon that is injured in Colles fracture is extensor pollicis longus tendon. Several times repeated MCQ. Okay? Yes. Now, coming to the next fracture, distal radial fracture, which is called Smith fracture. The Smith fracture is otherwise called reverse Colles. What happens? Dorsal tilt, dorsal displacement happens in the distal fragment of the Colles fracture. Instead of dorsal tilt and dorsal displacement, here we are getting ventral tilt and ventral displacement. Look at here. So, instead of this segment, when it comes here, this is called dorsal tilt. It going to the volar aspect, that's called ventral tilt. or volar tilt or ventral tilt, then that's called the reverse Colles, otherwise called Smith's fracture. Reverse Colles fracture is called Smith. This is fall on outstretched hand in a fluxed, that is extended hand. Fall on outstretched hand is a extended hand, Colles fracture. This is fall on outstretched hand in a fluxed hand, very rare. So this lead on to a deformity. That Colles fracture, the deformity is called Dinner-Folk deformity. Here the classical deformity is called Gordon-Spade deformity. Gordon-Spade deformity. Gordon-Spade deformity. Treatment. You can try closed reduction, but best management, since there is a volar chip, no, it should be treated like your Barton's fracture. Open reduction internal fixation with T-buttress plate, otherwise called the Ellis plate, is the best management for Smith fracture. So, it may be a catchy question in our NEET or INI-CET. The best management for Colles fracture, conservative. Best management for Smith fracture, surgery. Yes, okay, good. So, look at, this is the difference. So, fall on outstretched hand, there is a dorsal tilt of the distal fragment in extension. This is fall on outstretched hand in flexed position of the hand. The distal fragment is displaced volar or palmarly in ventral aspect. This on the dorsal aspect. That's the difference. This is Colles, this is Smith, right? Coming to the next very important fracture, scaphoid fracture. Okay, so already I told you the most common fracture of young adults is scaphoid, and anatomy or articulates is 5 bone, that's not all okay. Scaphoid lies in proximal row or distal row. This is a very commonly asked question in anatomy. They taught that please try loose shirt, too tight can't help. All these mnemonics are that she looks too pretty, try to catch her. Many mnemonics we have read in undergraduate life, and the standard teaching in anatomy is scaphoid lies in the proximal row. That's not accepted in orthopedics, and it's not logically right also. Okay, God has given us 8 carpal bones, dear friends. Fall on outstretched hand, most common carpal bone to undergo fracture is only scaphoid. What happens to the rest 7? We should think. So scaphoid doesn't lie on proximal, it doesn't lie on distal purely. This is the only carpal bone which lies on both rows. Because in other carpal bones, we have never read proximal pole, distal pole. Scaphoid has a proximal pole, distal pole. So proximal pole rests on proximal row, distal pole rests on distal row. Waist of scaphoid is unsupported. So whenever you fall, waist of scaphoid is gone. That's why the most common site of scaphoid fracture is waist. You see, main blood supply of scaphoid is branched from the radial artery, which enters through the distal pole. The waist is gone. Proximal pole will go for avascular necrosis. That's the dreaded complication of any scaphoid fracture. You see here. See, most common carpal bone to get fracture is scaphoid. Other are not very important. Most common carpal bone to undergo dislocation is lunate. Okay, this is the most common carpal bone to undergo dislocation. Most common carpal bone to undergo dislocation is lunate. Most common carpal bone to undergo fracture is scaphoid. Very, very standard questions, and most common young adults. Okay, this I already told. Most common site of scaphoid fracture is waist. Okay, waist. You see here, see scaphoid, waist. This is the most common site. Then proximal pole can get damaged, distal pole. These two are very rare. Common site is waist. Radial artery enters through the distal pole, comes to the proximal. When waist is gone, this will go for AVN, avascular necrosis. That's the teaching. Yes. And the most common mode of injury that results in scaphoid fracture is fall on outstretched hand. Okay, fall on outstretched hand. Most important clinical sign is very severe pain, fullness and tenderness in the anatomical snuff box. When you want to palpate the scaphoid, you know this is the anatomical snuff box. When you give deep pressure, you are palpating the scaphoid. You are palpating the scaphoid. Whenever there is fullness and tenderness of the anatomical snuff box, scaphoid fracture. Suspicion of scaphoid fracture. And the classical deformity of scaphoid fracture, so far unasked in any of the Indian entrants, because the classical deformity of Colles fracture is Dinner-Folk deformity. Classical deformity of Smith fracture is Gordon-Spade deformity. Everyone knows that. The classical deformity of a displaced scaphoid fracture is called humpback deformity. It is called humpback deformity. Okay, it is called humpback deformity. It's called humpback deformity. Okay, so that is the classical deformity of scaphoid fracture. And there are 2 clinical tests to diagnose scaphoid fracture. One is called scaphoid lift test. Another is called Watson's test. Scaphoid lift test is just when you just give a volar your dorsal and volar tilt of the wrist, severe pain is elicited in the scaphoid. That's called scaphoid lift test. Another test is called Watson's test. What is that? Pain is produced when the wrist is moved from ulnar to radial deviation. You just keep in a fully ulnar side of the thing over a table, ask the patient to move the hand from ulnar side to radial side. Severe pain is felt over the scaphoid, and this is called Watson's test. So, two clinical signs: scaphoid lift test, Watson test. In a displaced scaphoid fracture, you get a humpback deformity. And on giving pressure to the anatomical snuff box, severe pain is elicited in the anatomical snuff box. 1, 2, 3, 4. Okay, 4 important clinical signs, scaphoid fracture. The X-ray view of choice in scaphoid fracture is an oblique view like this. Oblique view means keep the hand deviated totally ulnar, okay, and pass the beam. This is the scaphoid is highlighted. You see, I am able to see the scaphoid well. This is the scaphoid bone. This is the scaphoid bone. Okay, so I am able to see that well. The view of choice is oblique view, other is called scaphoid view. You see, if there is, clinically you are suspecting scaphoid. You are clinically suspecting scaphoid. You took a proper oblique view digital X-ray, but you are not very clearly able to see a clear fracture line. Treat that as a scaphoid fracture. Clinically you are suspecting scaphoid, radiologically not able to prove. Don't worry, you just give a scaphoid cast, below elbow POP cast, a scaphoid cast. Repeat the X-ray after 3 weeks. When you see a healing fracture line, leave that cast for 10 weeks. Even after 3 weeks, it doesn't show any radiological sign of fracture, release the cast and leave the patient free. Because over-treatment is nothing wrong as far as scaphoid fracture is concerned, dear friends. When you miss scaphoid fracture, the very initial thing, the dreaded complication is avascular necrosis and non-union because of avascular necrosis of the proximal pole of scaphoid. Okay, so that's very, very important, dear friends. And that's why nowadays they are telling MRI is a preferred investigation over X-ray as far as scaphoid fracture is concerned, because MRI usually won't miss a fracture line and it will pick up AVN in the very early stage so that screw fixation can be tried. So MRI detects scaphoid fracture much earlier than the X-ray. So that's the thing. Coming to treatment, undisplaced scaphoid fracture. Most of the scaphoid fracture unites by scaphoid cast in 6 to 10 weeks. Scaphoid cast is otherwise called Bowler gauntlet. Scaphoid cast is otherwise called Bowler gauntlet cast. Scaphoid cast is otherwise called Bowler gauntlet cast. What is that cast? It's a below elbow POP cast in tumbler holding or glass holding position. Like this, as if you are holding a tumbler, holding other is a glass holding position. This is called Bowler gauntlet cast, below elbow POP cast in glass holding position. Right, displaced scaphoid fracture is treated by Herbert screw. It's treated by Herbert screw. Okay, the main complication of scaphoid fracture is non-union and avascular necrosis of the proximal pole. 40% of proximal pole and 1% is distal, and the main complication of scaphoid fracture is avascular necrosis and non-union of the proximal pole of scaphoid. This is called Pre-Sears disease. Displaced scaphoid fracture means fix it with a Herbert screw. This is the Herbert screw. Okay, this is the Herbert screw. What is the peculiarity of Herbert screw? You concentrate. The screw doesn't have a head. Usually a screw will be like this. No, a screw, it will have a head and the screw will be like this. The screw should be like this. But in this screw doesn't have a head. So Herbert screw is a headless screw which can be buried inside the bone. Once you had just buried inside the scaphoid, no need to remove it back. Okay, so Herbert screw. If it's a displaced fracture, immediately do a Herbert screw fixation which will prevent avascular necrosis and non-union, re-establishes the blood supply. Okay, dear friends, we will move on to another very important chapter, Bennett fracture. Okay, Bennett fracture, Rolando fracture. Okay, both are fracture base of the first metacarpal. If it is oblique intra-articular fracture of the base of the first metacarpal, that is thumb, then it's called Bennett. You should know Bennett, Rolando, both are intra-articular, both are base of the first metacarpal. When the fracture pattern is oblique like this, okay, you see this, oblique like this, then it's called Bennett. If the fracture here is comminuted, then it's called Rolando. That's the only difference. Okay, most common mechanism of Bennett fracture is axial blow directed against a partially flexed metacarpal. It's like this fist fighting. Okay, this is called fist fighting. So it's called fist fighter's fracture. And treatment of choice, even though it's a very small fracture, open reduction internal fixation with K wire is a must. Okay, because there is a big problem, dear friends. You see, this whole bunch is one proximal fragment. This is the distal fragment. You see here this fracture. So this distal fragment is attached to abductor pollicis longus tendon. So even though a vertical fracture happens, the small bit is here, the big chunk is here. That big chunk is attached to abductor pollicis longus tendon. Constant pull by abductor pollicis longus tendon. So unless otherwise you fixate, this won't allow the fracture to heal. This may go for non-union, especially it's intra-articular also. So it needs fixation. That's the very peculiarity of Bennett fracture. Number 2, Rollando's fracture. Rollando's fracture is the same thing. It is intra-articular fracture at the base of the tongue, which is comminuted. Look at here, you see here, the base here is totally comminuted like this. Then it's called Rollando's fracture. It is open reduction internal fixation with mini screw is the treatment of choice. There one K wire is enough. Here it needs a screw fixation because it's thrown into many pieces, comminuted. You see the difference, dear friends. In Bennett fracture, it is just an oblique intra-articular fracture at the base of the first metacarpal. Here, this is comminuted fracture at the base of the first metacarpal. That's the difference, okay? And you can see very well, this is the very important question. It is pulled by abductor pollicis longus tendon. That's the problem that hinders union in case of Bennett's fracture. Now, coming to another very important short topic, mallet finger. What is mallet finger? This is otherwise called baseball finger, this is called drop finger. This results from injury to the extensor tendon of the terminal phalanx. For example, this is the terminal phalanx. In a hyperextended state, sudden unexpected force flexion of the terminal phalanx, the extensor tendon is cut. Okay, so the finger will become like a mallet. So this is called mallet finger. Okay, so this results from injury to extensor tendon. It is due to forced flexion of distal phalanx while the extensors are actively trying to extend the finger. For example, this is very common among staff nurses and nurse trainees. Especially, I had seen many cases in my hospital. You see, there is a process for all the nurse trainees, okay? Diploma in nursing, BSc nursing. There is a procedure called bed making for them, bed making. See, they have to tuck the blanket underneath the mattress. So that we used to tuck the blanket like this with the hyper-extended fingers like this with full power. Suppose some screw, nuts, bolt, something is there, some obstacle is there. Unexpected sudden force flexion of the terminal phalanx. The extensor tendon is cut and the finger will become like this, and that's called mallet finger. Right? The treatment of an acute mallet finger is splinting with acute mallet finger splint. You see, with the acute mallet finger splint. Or with the old, this is Smiley's cast. This is of historical importance. What we are having, mallet finger splint for 8 weeks. Surgery is generally not advisable. Okay. Now coming to a revision of the upper limb trauma, the most common vessels injured. Most common vessel that's injured in fracture clavicle is subclavian artery and subclavian. Most common vessel that's injured in proximal humerus is axillary artery, axillary. Most common vessel that's in the shaft of humerus is brachial artery. Most common vessel that's injured supracondylar fracture, again brachial artery. These are all vessels, not nerves, vessels. Posterior dislocation of the elbow, again brachial artery. Most common both bone forearm fracture, anterior interosseous artery. Anterior interosseous artery, right? So these are the common vessels that are damaged in upper limb trauma and common nerves that are damaged. This is a revision for us. Fracture clavicle, it is medial cord of brachial plexus. Okay, medial cord, especially ulnar nerve. Okay, most common nerve that is in proximal humerus is axillary nerve. Most common nerve in shaft of humerus, radial nerve. Most common in supracondylar fracture, anterior interosseous nerve. Most common posterior dislocation elbow, median nerve. Most common in Monteggia fracture, posterior interosseous nerve. Most common nerve in hook of Hammett, deep branch of ulnar nerve. Deep branch of ulnar nerve. Okay, ulnar nerve. And most common wrist injury, median nerve. Any wrist injury, that is carpal tunnel syndrome, a median nerve. Okay, right? Fracture clavicle, it's ulnar nerve, proximal humerus axillary nerve, shaft of humerus radial nerve, supracondylar fracture anterior interosseous nerve, posterior dislocation elbow median nerve, Monteggia's fracture is posterior interosseous nerve, hook of hamate, it is deep branch of ulnar nerve, wrist injury, it is median nerve. Okay, yes. Now let us revise the named fractures of the upper limb. Holstein-Lewis fracture, we all know it is oblique or spiral fracture, lower third of the shaft of humerus with radial nerve injury, Holstein-Lewis. Monteggia's fracture is fracture upper third ulna with radial head subluxation. Galeazzi fracture is fracture lower third radius with distal radial ulnar joint disruption. Piedmont fracture is another name for Galeazzi fracture. Treacherous fracture is another name for Monteggia fracture. In fracture of necessity, there are two fractures of necessity. One is Galeazzi fracture is fracture of necessity. Another is lateral condyle fracture. Lateral epicondyle fracture in a humerus, in the case of child, is also called fracture of necessity. Fracture of necessity means 100% surgery is necessary. Yes. Then Essex-Lopresti fracture is combination of Monteggia and Galeazzi. It is comminuted fracture radial head with distal radial ulnar joint subluxation. Potto's fracture is the old terminology for Colles fracture. Nightstick fracture is an undisplaced crack fracture of the ulna because of a blow by a nightstick. Okay, usually that results from assault. Smith fracture is otherwise called a reverse Colles fracture. Barton fracture is a vertical marginal intra-articular fracture of the distal radius. Hutchinson's fracture is another name for radial styloid fracture. Bennett fracture is oblique fracture, intra-articular oblique fracture at the base of the first metacarpal. When the same thing is comminuted fracture at the base of the first metacarpal, which is intra-articular, is called Rolando's fracture. Boxer's fracture is fracture shaft or neck of the fifth metacarpal. Fracture shaft the neck of the fifth metacarpal. Malgagny fracture is another old terminology for supracondylar fracture. And Babycar fracture is it is collision injury and it is shattered elbow in a case of child. Okay, opposite collision happens, side sweep injury of the elbow in a child is called Babycar fracture. To some extent, we have completed the upper limb trauma.